Hello, my name is Kyra Douglas, and welcome to my presentation on rhabdomyolysis. Some of the topics discussed within this presentation have been shown below. Case study. We will talk about a suspected case of rhabdomyolysis and some of their symptoms. What is rhabdo? We will talk about how rhabdomyolysis is defined within literature, what it is and the forms it can take. Initial presentation. Its initial presentation, like signs and symptoms, can be compared to that of the case study. What happens? We're going to talk about what happens physiologically within the body when rhabdomyolysis occurs. Why has it happened? We will talk about what may have caused it to happen. Here we have a patient with a suspected case of rhabdomyolysis. When advancing through the presentation, we hope to find evidence that confirms their diagnosis as well as signs or symptoms that may be present within literature that the patient may not be suffering with, therefore presenting additional questions and tests that the patient may need to undertake. A 27-year-old male was experiencing intolerable pain of the quadriceps, which he reported firstly felt like delayed onset muscle soreness, but after hours of rest became significantly worse. Before attendance to hospital, dark-coloured urine, similar to that of Coca-Cola, was observed. Prior to this, he had been simulating a CrossFit competition workout, focusing specifically on resistance work. However, his previous sports training was mostly of an endurance nature and has previously competed in triathlons before his focus switched to CrossFit. And of the 2 months of training that he did, it was mostly dedicated to his lifting technique. Examples of both training regimes can be seen in the tables on screen. Once admitted to hospital, it has been said that his creatine kinase levels were in excess of 10 times the normal levels, and myoglobin in his urine was found when tested. The patient could barely actively flex their knee, and a gait assessment was abandoned due to his inability to walk. In literature, later researchers have avoided giving a definitive definition as to what rhabdomyolysis is, as it is still said to be a working subject area. Though in their reports, earlier literature definitions have been used and additional research follows. Melly and colleagues define rhabdomyolysis as being a clinical and biomechanical syndrome resulting in necrosis of skeletal muscle fibres and leaking of muscle cell content into the bloodstream. This definition has been echoed throughout literature, though most definitions then go on to explain that significant tissue damage has to occur to initiate the process of the tissues depleting. For example, it could be because of the patient having an already present disorder or overexertion of the tissues. Napick and O'Connor explained that rhabdomyolysis can take another form depending on it occurring from overexertion from physical exercise. Therefore, exertional rhabdomyolysis, or ER, can occur due to an individual performing so much physical activity that they deplete muscle energy stores. As a result of this, the cellular integrity is compromised and cell damage may occur. It can be suggested that the case study may be suffering from exertional rhabdomyolysis, as it was reported that his nutrition and health was very good, and his mechanism of injury seems to be consistent with that of physically demanding exercise because of his switch from regular endurance to rapid repeated weighted CrossFit exercises. On the screen is a table showing the signs and symptoms most prevalent within literature. Most recent reports show many more signs and symptoms than that of some later studies. This could be because of the medical advancement that has occurred over the years, as within Gabal and colleagues' study they revealed that 8 patients died whilst their study was being completed. Upon reading their report, only 2 signs and symptoms were listed, as all of their patients already had rhabdomyolysis. So instead of taking measures to diagnose early onset and give treatment, they opted to test the physiological and chemical imbalances that happen after it has occurred. This paper may not be useful in modern medicine as it may be seen as unethical and does not offer early treatment options. Compared to that of other researchers, a long list of signs and symptoms have now been compiled. Fernandez and Davenport, also Miller and colleagues, were seen to have highlighted the most. The signs and symptoms in bold are in relation to the case study, as none of these were reported nor observed. Clinicians should aim to ask or assess their patient on some of these. Apart from high creatine kinase levels, it is unknown as to what sign or symptom is the most prevalent when rhabdomyolysis occurs. The literature does not show clear information as to what actually happens for exertional rhabdomyolysis to occur. Conversely, rhabdomyolysis occurring because of drug use, crush injury, or a predisposed condition seems to be the most prevalent. It has been said that contractions of the muscle in an eccentric manner put a strain on the muscle, specifically the sacrolemma. When tears occur, deeper damage to cells can happen, resulting in protein and calcium entering the cell. With large quantities of calcium, it can trigger persistent contraction, resulting in energy depletion and cell death. When released into the blood, the myoglobin and calcium protein can be seen within the urine, as after it enters the blood, it passes through the kidneys and is filtered out with the urine. High levels of creatine kinase can be found because of the depletion of the ATP system and cell damage, and is flushed into the kidneys and out into the urine with the myoglobin. There have been many causations of rhabdomyolysis identified within literature, though for exertional rhabdomyolysis, overexertion of the muscle through exercise is seen to be the main cause. However, Fernandez and Davenport highlighted other exertional causes which may not be caused by exercise but exacerbated by it. They found that patients with metabolic diseases such as McArdle's disease, which is an inability to store glycogen as an energy system, can be triggered after intense exercise and shows high levels of creatine kinase within their system. For a sports therapist, this information would be out of their scope, as they would not have the ability to medically test their patient to identify this hereditary disease. It is believed that more research should be done to find out the causes of exertional rhabdomyolysis, as the information available is not sufficient for sports therapists at the moment.